Hello and welcome to another instalment of Health and Wellbeing Live. We're having conversations to improve the health and social care of patients in Nottingham City. And today I'm joined by Julie and Carl, and we're going to be having a conversation about improving end-of-life care, and in particular, the use of the EpaCCS tools across our clinical systems in general practice. So hello, Carl. Hello, Julie. Do you want to introduce yourselves?
Shall I go first? So I'm Julie Barker. I'm a GP, been around the patch for a while, and I'm also the clinical end-of-life lead for the ICB. Over to you, Carl.
Hi, I'm Carl Ellis. I'm a programme manager working in the Mid-Notts and North Notts area. And I'm part of the End-of-Life Care Together Alliance, and my job title is the Head of Service for End-of-Life Care Together.
That's great. And I guess I better introduce myself as well. I'm Andy Foster. I'm a GP as well. I work in Bulwell in the north bit of Nottingham, and I'm the Deputy Clinical Director at Nottingham City Place-Based Partnership. But the EpaCCS tool is used across Nottinghamshire. Is that right, I think, Julie?
Yeah, absolutely. So originally it was all of Nottinghamshire with the exception of Bassetlaw, and actually it was
Bassetlaw was included in the original rollout.
Part of the ICB.
No.
But now we've embraced them as our brothers and sisters. So, so we were visionary right at the beginning. We knew what was down the line.
Excellent. Good. So I guess just to give people an idea of what we'll be covering today. So we're going to be having a discussion about like the impact that good end-of-life planning has and the positive impact that it can have on patients and on services and staff working in services as well. We'll be talking about the importance of using communication tools well that communicate people's wishes and those end-of-life plans across the system. And spoiler alert, I guess that is EpaCCS that does that job across our system. We'll be talking about the importance of keeping those plans up to date because they can change as people and as patients' situation changes and deteriorates towards the end of life. And we'll also be talking a little bit about how making sure that we code well and record accurate data helps with sort of the planning of services and demonstrating that the things that we do are effective and that we're doing good work across the system. But probably a good place to start is just a description about kind of the purpose of EpaCCS. I don't know if one of you wants to just explain the general purpose of the system.
Shall I kick off, and then if I miss anything, Carl, you can come in,
please.
So it's essentially a database that records key information about where people are at in their end-of-life journey, starting from when we first pick up that they may be reaching the last 12 months or thereabouts of life. However, recently we've extended that to acknowledge the fact that some people benefit a lot from advanced care planning at an earlier stage, thinking particularly of moderate severe frailty and dementia. So we're incorporating those cohorts into our, let's say, target lot of patients. And the important thing is that it's a method of sharing information across key care partners across the system. So although it's written on the System 1 module that we have in the community, and we know that hospitals and other organisations such as EMAS don't have System 1 in the same way that we do, they can see coded information, and that information will also be pulled into the NOTS Care Record, which is coming on stream this year. So it's going to be increasingly useful and important that we keep it up to date.
Okay, that's really, really useful actually to know that information is visible and useful across the system to really incentivize people to participate and use it. I actually just thought, can we talk a little bit about just the why good end of life planning is important and some of those sort of fundamentals so that people can understand why it's important to engage with a tool like EpaCCS. And I've got some slides queued up if you want me to share some of those slides.
Yeah, why not? Let's do it. Quote that's coming up from one of our key leaders is so apt for end of life care. We will all know, either patients or family members, unfortunately, and this applies to me and is the main reason why I do what I do, that when you don't acknowledge that somebody is coming to the end of their life, they get substandard care quite often, unfortunately. And we don't want that for our patients, loved ones, etc. So advanced care planning is essential, really, to make sure that we do give the best care to our patients. And if we're putting our selfish hats on, it reduces crises contacts for us in primary care and in A&E and in EMAS, right across the patch.
Yeah, I mean, it's good for everybody, isn't it? And Julie, when I go out to end of life visits with students, I often tell them, I say, people only die once. Maybe it sounds a bit like a James Bond film, but it's really true. And people's families really remember the sort of care that they received, around that time of their loved one passing.
Yeah.
And it's actually one of the most impactful parts of our work in general practice, in my opinion.
It's interesting
so
you say
really
that,
important.
Andy. Yeah, because having just recently retired as a partner at my practice, I saw a lot of patients that I've known for years, but what they commented on was the end of life care I gave to their mother or their father, which I've forgotten about, but they remember. And it was really quite sobering for me and humbling that that's the kind of thing that is remembered as a legacy, I suppose.
Yeah, absolutely. So let's talk through some of the other reasons why it's important, Julie. Talk us through some of these slides, and I'll go to the next one when you give me the cue.
Okay. So most people who are listening to this will be aware that we're trying to think about care provided on a population-based level as an ICS, as well as an individual level as a person. So just in the same way that we think about our patients in a holistic way as general practitioners, we don't see them as a disease. We see them as a person with, a mind and a heart and a family and priorities. We're looking at our population as cohorts with general needs as well as specific needs. And this changes the way that we plan services. So EpaCCS gives us information which then provides key codes for our database, and many of the audience will know that Nottinghamshire has one of the best databases in the country, and actually it's something that nationally we're known for. And we have our IT geeks across the county to thank for that. And you know who you are. This information, for those of us working in systems and in commissioning, is vital for how we plan services, for how we target resources to the areas that need it most. So we'll talk about the types of coding information that EpaCCS gives us in a little while. So next slide, we might have a few clicks here.
Oh, there we go.
Right, so one or two people might have come across this slide before. This was my senior fellowship slide, and shout out to the Phoenix programme here. I was able to do an audit of respect, form, quality. Again, it's that what if question. Why does advanced care planning matter? What difference does it make for the patient primarily, but also for the system as well? And what I found was that the detail, particularly in the box 4 treatment escalation plan on the respect form, correlates very closely with outcomes for the patient. So if you have very little information on a respect form, if it just says ward-based care or that they're not for resus, you don't get a terribly good outcome. However, if you've got the preferred place of care on there, that patient does not want to go to hospital for anything other than a major fracture, that their COPD can be treated in a certain way at home, that kind of information really makes a big difference, results in fewer emergency admissions, transfers to hospital. If you and also, actually, as I've said on there, fewer fast track packages, which of course is of big interest to our funders.
Yeah, this slide's really, really good. So we shared this with our team, and as you say, it's just really great slide for making that connection between the quality of the information provided in the respect score and the outcomes for the patient and the system, which improve as and it doesn't, it's a little bit of additional sort of effort or thought to give more detail in terms of the quality of the information in box 4, but it has a big impact, and it's just important for showing that it does have an impact. It does matter how well you fill the respect form in.
Yeah. Absolutely. We spend a lot of time in these conversations, and we want to know that it makes a difference.
And did you want to move to this slide now, Julie, or? Yeah.
Yep.
There it is.
We know from our data that we are missing approximately 50% of patients who die still. Don't get me wrong, it's good nationally that we are picking up 50%, but we've still got a piece of work to do in finding the rest. So this links to the eHealth Scope workflows. There is a link on the EpaCCS template, which you'll see in a bit. And it shows some of the indicators that we have at our disposal, that where we can find patients that we don't currently have on our EpaCCS template and we haven't yet offered respect forms to. So if you've got registrars in practice who are looking for a quality improvement initiative, this is a brilliant one to do, because it so improves care for patients if they're picked up and offered that conversation.
Yeah, fantastic. And I think we expect to have about 1% of patients on our end of life register. Is that right, Julie and Carl?
Yeah.
For the last 12 months of life, yeah, we expect. So the Finding the 1% initiative, which was a national initiative, was around recognising that 1% of the population dies each year. What we're advocating here is that actually, if we look a little bit deeper at our frailty registers, our dementia registers as well, actually that early identification means that potentially we could be looking at 2% of our population at any one time, those that are going through the last 12 months of life, and the ones that we expect next year to go through the same process or in 2 or 3 years' time. So it's really positive from that perspective, that finding the 1% is that focus around end of life, but we're also being proactive and looking for the next cohort of patients and preparing for their next stage of their life as well.
I was just going to pause there and just ask a few more questions, actually, because one of the things that we were talking about before we came into the recording was about how important it is to communicate the end of life plan across the system, so that our other partners who work with us in the community understand that the wishes and plans. And I was wondering if one of you could just talk a little bit more to that question in terms of why is it important to record these wishes and information in a way that is communicated and visible across the system? How does that help?
So as a GP, obviously, we're all aware of patients, whether they be at home or in a care home, who let's say something happens, they might get an infection and deteriorate. If we have this kind of information in place, we can make sure that one, we know their priorities for themselves. An example would be a guy I saw at home with advanced cancer the other day. He wants to live as long as possible, but he's realistic. He knows he's not going to. He's got an incurable cancer, and he's currently on chemotherapy and doing well on it. Now, he was very clear that he wants everything going to keep him alive as much as possible at the moment. But he's also very clear that should his condition change, he would want to change what we currently have on his respect form. Conversely, I've also had a conversation with a patient at home who is very frail, supported by her family, and she is adamant that she does not want to go to hospital under any circumstances. Maybe even if she fractured a hip, she wouldn't want to go to hospital because she wouldn't be fit for surgery. So we talked through those scenarios and how we can help those two very different people, each of them on our end of life register, achieve what's important to them. So if say they both fell and EMAS came out and assessed them, their approach would be very different with those two people. So that really gives us it gives them a clear steer on why it's useful to have it, one, coded so it'll appear on the NOTS care record, and two, clearly articulated in their respect forms.
And as a program manager, sorry.
Go on, Carl.
I was just saying, as a program manager, I often come across cases where we are talking about where care has sometimes fallen down, and we've got lots of examples of patients that have a respect form and have clearly indicated that they don't want treatment at all costs. However, unfortunately, either the respect form has been lost, or it's not scanned on system 1, or it's not been communicated with other partners, and unfortunately the patient's then been admitted and unfortunately died within 24 or 48 hours of that admission. So again, it demonstrates the effectiveness of good sharing, of good recording from the EpaCCS system will enable other practitioners to make the best decision for that patient.
Yeah, and I was just going to add, in conversation with with our partners at EMAS and at NEMS, for example, they really value the information that's on respect forms and that's in EpaCCS to support them in making the right decision for the patient, because they haven't met the patient before, or the family's acute deterioration situations are really complicated, and they really value good quality, detailed plans from us in primary care, and it really makes a difference. So I was just iterating that, and then I was also just going to make the point again, just thinking about a fairly recent scenario where actually somebody's situation changed quite rapidly, and I think fortunately we did update the respect form in time, but I can imagine scenarios where actually somebody's wishes just a few weeks before, when they were in a different state of health, can be very different a few weeks later after they've had an acute deterioration. And it's just so important that we keep revisiting the respect form when the situation changes. Absolutely. Because that person could have been left with completely the wrong thing written on their respect form, and that could have been very damaging to them having the end of the life that they ultimately wanted. So just so important to update them, I guess, as well.
Actually, one of my hospital colleagues was saying this morning that that makes such a difference when they see patients in hospital as well, when it has been updated, because their steer is so important.
Yeah, that's really good. Carl, I'm just going back to the slides, because there were a few slides that you'd identified to help tell a bit of a story around the background of EpaCCS and the data. And then I guess we'll get on to the live demonstration so people can remind themselves, how the tool works, and we can show what the key bits are to complete. So let's just go back, Carl. So I'll hand back to you.
Yeah, thank you. I mean, it's just to really celebrate what Julie's already highlighted, that nationally we're recognised as one of the best systems in terms of having an EpaCCS in place. So as you'll be aware, the EpaCCS template is on every single GP practice system, both System 1 and EMIS across the whole of Nottingham and Nottinghamshire, and that then obviously feeds into eHealthScope, which is how we collect our data. But just to demonstrate in Mid-Nots, the area that I work in particular, that we started in 2018 as an alliance with a baseline of of 1,700 patients identified on the end of life care registers, and that's close now to 3,000. And if we're looking at the finding the 1%, that's 0.87 of the population. So we're very close to that finding the 1%, which we're incredibly proud of. In terms of respect wasn't implemented until 2019, so we started with a 0 position, but we now have over 2,100 patients now with a respect form in place. And again, in terms of looking at the data, we've also identified that preferred place of care isn't being recorded on the EpaCCS template. We're not saying that the conversation isn't taking place with the patients to understand what their wishes and preferences are, but it's not necessarily being recorded on the EpaCCS template. So therefore, we don't have that process through the connected knots and the shared care record about how to communicate that with other practitioners. So it's almost as though the information has been recorded in a way that's being kept to the individual practitioner and not necessarily being shared. And the whole purpose is to try and advocate that patient's wishes and preferences as often as possible. So it's a really good demonstration of where we are, but also a celebration of how we got there.
That's great. Thanks for that information, Carl. And I suppose that's a really key learning point for us, I guess, is actually please record the preferred place of death on the EpaCCS. That's one of the key bits of information that help us understand whether we're being successful as a system. And actually, it's a really key thing to know, isn't it? When a partner in outside of normal hours is assessing a patient, they need to know that.
Yeah, absolutely.
And then I think we've got some data. So it's I think it's a little bit blurred actually, which is probably no bad thing because it's about individual primary care networks. But was this data helping us tell a bit of a story, Carl? Do you want to just whiz through?
It helps us to identify the total EpaCCS population across the whole of Nottingham and Nottinghamshire. So again, looking at that ICB average, we've gone from 0.68% as an ICB to 0.73. So again, it really demonstrates the passion in Nottingham and Nottinghamshire around that identification and how we're really starting to build those registers. The way that this is presented just helps us to then focus on areas where we can look at the population in a little bit more detail, how we can support those local PCNs and how we can really start to build those registers. And, I think there's a fantastic piece of work that's already happening in Nottingham and Nottingham City around how they can start to do that, which is absolutely fantastic. Do you mind going on to the next slide, please?
Absolutely.
So again, I think we were talking a little bit earlier around how we're going to use this data, and on the workflow that Julie showed earlier was around the care home population not on the end of life care register. If we look at overall, only 46% of our elderly population in care homes are actually registered on the EpaCCS. So again, this is another opportunity to think about how, as individual practices, we can start to build up our registers to identify that population. And again, we're advocating why that is important. It's so that other partners in the health economy can actually make informed decisions based on the information that's held on EpaCCS. So again, it's just a demonstration here of how we can potentially use this data to inform services in the future. Mm-hmm. And again, this is looking back again at the number of patients actually achieving the preferred place of death and the percentage of the population that's having preferred place of death recorded. And again, this just demonstrates again an area where we can start to work on as a system to making sure that we're using the EpaCCS template as the central place of recording that information.
Thank you. Let's go back to the view where we can see all of us. Not that one, this one. There we go. Yeah, that's great. Yeah, and actually, if practices, I guess, are looking for the lower hanging fruit in terms of identifying patients who might require EpaCCS and respect, going to the care home population is a really good place to start. And I guess most practices will be doing care home rounds, so that can become, a part of the routine discussions at the care home rounds. And often care homes are quite helpful actually in terms of identifying people who don't have a respect form for you. If you ask them to go away and generate a list, they're normally quite keen to do that because part of the guidance is that they should have these in place for their patients as well, so they're also motivated. So that's really positive. Go on, Julie.
The care navigators are also brilliant at helping identify these patients as well, because they regularly interrogate the data and pick up the cohorts proactively. And going back to the care homes, they will notice if someone's deteriorating slowly, and hopefully if they bring them to the home rounds, then that again will be just that nod to say, okay, let's start the conversations going. Our care home colleagues will take a lot of that initial valuable information that we can then use to populate the box for.
Absolutely. And I probably won't show it on screen because this is public, but the SAIU, Systems Analytics Intelligence Unit, most practice managers have access to this. And there's a live dashboard that people can look at in terms of what proportion of their population are registered for end of life, what proportion of their care home population have EpaCCS or have are on their end of life register, what proportion of those populations have preferred place of death. And I think you can link through to eHealthScope, but there's definitely eHealthScope dashboards that help you identify the specific patients and kind of take that quality improvement activity forwards. I won't show it on screen because we're sort of in a public place, I guess. Is there anything that you want to add before we sort of wrap up, Julie or Carl?
No, I think you briefly showed the toolkit. So just a shout out to the NOTS End of Life toolkit, suitable for all staff across the system, and it's open to patients who can access some of the key information. So everything that's worth knowing is on there, including the Respect example suite of box 4 that you referred to, Andy.
Excellent. Good.
And I think the other thing as well, as Julie's alluded to, is that we're constantly evolving the EpaCCS template. So we really value clinicians' feedback on how it's utilised and areas where we can improve, because we want to make it as fit for purpose as it possibly can be.
Good. So I guess that brings us to the end of this video. So thanks everybody for joining us. Thank you, Julie. Thank you, Carl. And take care, everybody.